Hello, everybody. Thank you for hanging in there. The last two sessions, after a long week, I hope you've had fun. You've learned a lot of things and had a lot of good interactions. As Gerold said, I'm a fan of ultrasound, and my talk was called Renal Ultrasound for the clinical nephrologist, but I put it in parentheses because I think it's very valuable to actually extend it beyond using it just for kidney imaging. And there's a lot to be said about knowing how to do a volume exam with the extension of an ultrasound. Who in the room is already doing ultrasound, if I may ask? Any hands going up? Great. It's more and more every year, so that's exciting. Very good. All right. I have no disclosures, and we'll start as usual with a case. And this is the case of a 24-year-old woman who had no significant past medical history. She suddenly had swelling and discomfort and an episode of nausea and vomiting. She comes into the emergency room. Her blood pressure is a little bit on the high side. Her weight is up. Her edema are not impressive, but clearly she has 15 pounds of weight increase. Her sodium is low, potassium is high, creatinine is high, bicarbonate 20, and she has RBCs, white blood cells, and protein in her urine. And here are the pictures of her ultrasound. And you see the right kidney, all the way on the left side of the screen, and the left kidney here. So take a good look, because I'm going to ask you questions about it. All right, so the questions are, do we have normal-sized kidneys without evidence of hydronephrosis on the right? Do we have normal-sized kidneys with hydronephrosis on the right? Do we have normal-sized kidneys with cysts on the right? Or do we have small kidneys without hydronephrosis or with hydronephrosis? I'm going to show you the pictures again, if I can go back. There we go. So the question was, one, about the size of the kidneys, and two, are there cysts, hydronephrosis, or nothing on the right? Okay. And now you can use your your voting button. Give you a few minutes, seconds. All right, let's take a look at what everybody's thinking. Oh boy, it's a little bit all over the place, but I know why. Of course, I've written this question, so I kind of tried to challenge you a little bit on the first slide. We'll get to the answers a little bit later. So a lot of you said normal-sized kidneys without evidence of hydronephrosis. Actually, the majority, and C was normal-sized kidneys with a cyst. And third place was hydronephrosis and normal-sized kidneys. Very good. Yep. All right, so let's think a little bit about ultrasound. So ultrasound uses probes that have crystals in there that produce a mechanical wave. And this mechanical wave will travel through the body, will encounter certain structures, and then the ultrasound wave will be changed, either come back to the probe, be scattered, be resorbed. And based on these phenomena, you will get an image that will be either black, white, or different shades of gray, which is typically used for the so-called B-mode ultrasound, which describes brightness. So a structure that will absorb everything will have no signal or be completely black on your screen, and anything that will reflect the ultrasound waves will be very bright. So therefore, and what are the structures that absorb things? Fluid absorbs all the ultrasound waves. Therefore, anything that is fluid will be completely black, and it's called anechoic. And everything that is completely reflecting everything, it will be bright and it's called hyperechoic. And those would be calcifications or other structures that have a very high density. And everything in between will be called hypoechoic and isoechoic. And typically, structures that are any type of grade shades are liver, kidney, spleen. And the other part is that other than the reflecting ultrasound waves and their intensity, how they come back, we use artifacts to interpret images. And I'm showing you here two artifacts, the one all the way on your left. It's called some dorsal enhancement. In situation when there is a fluid-filled structure, you'll see a black signal and then an increased signal behind the cyst. That's called dorsal enhancement. And it's very typical for cysts or the bladder. And on the other side, if you have hyperintensive signal with a black area behind it, that's called shadowing. And that's typically seen in anything that is calcified, like stones or bones. All right, and we need to look a little bit at the anatomy of the kidney. We have the cortex, we have the medulla. In the medulla, we have those triangular structures that you all know, the pyramids that are very relatively symmetrically distributed. In the middle, we have the pelvis, and the medial side, the vascular pole and the ureter. And this is how you then see things on the ultrasound. We always look at everything in two planes, longitudinal and transverse. Everything that is close to your probe is anterior and distant from on the other side of the picture, that's posterior. And in longitudinal cuts on the left side, there will be always the cranial direction or cranial part of the patient, and here the caudal direction, meaning this is the liver, the heart, and the head would be on this side. If you look at images in a transverse cut, it's like looking at the CAT scan. Everything that is right in a patient will be on the left side of the screen, and vice versa. So, shades of gray of the liver, and then behind the liver, in an anterior sagittal cut, is the kidney. The kidney sits on this striated structure, which is the psoas muscle, and then we have the pylon area where it's a little bit more hyperintense because of fat. And then we have this little hypoechoic, they're not completely anechoic areas, triangular structures, which are the pyramids as we have just looked at the anatomy. So going back to little kind of cystic looking structures, evenly distributed, those are often pyramids and not necessarily cysts. And then at the size of the kidney, what is normal, 10 to 12 centimeters is normal. If you have a difference of 1 centimeter on your report or while looking at the pictures, keep in mind that there is a reason for that, and more than 1 centimeter should let you think about scarring, either renovascular disease or post-obstructive. So what does it mean if the kidney is actually bigger? You can have big kidneys of 12, 13, 14 centimeters of size. Well, there are 3 types of pathologies. One is hyperfiltration. So diabetic nephropathy, even prior to developing albuminuria, will present as a big kidney. Preeclampsia, the same. An acute event where you have a lot of infiltrative cells, which could be GN or AIN, so an acute parenchymal disorder can lead to big kidneys as well as renal vein thrombosis. And then the third one is infiltrative disease, which could be myeloma or amyloid. This is an image of a kidney. You can barely see it as compared to actually, this is the left side, the spleen. On the other pictures, it looked more like about similar echogenicity. So the next thing that we'll look at is, or you should look at, is the echogenicity of a kidney. Anything that looks like this is hyperechoic, and it is big. This clearly speaks for an infiltrative disorder. And again, those dark shadows here, those dark areas, hypoechoic areas, are pyramids. If you look at this picture, it's a little bit the reverse at what we were just seeing before. So here is the spleen, to compare it, the parenchyma about the same echogenicity, and then these hyperechoic areas that we see that were in the position where we had the pyramids before that were dark. So what does it mean? Hyperechoic signal means infiltration or calcification. So this is a typical picture of someone with a medullary nephrocalcinosis. It's just one look. Once you kind of start seeing these things, you just look at the picture and you know the diagnosis. So it's very valuable to actually look at the images and not just take the report that is being given to you. So let's get back to our case. We have the size down here, it's 11.6 centimeters, so that's still within the normal range. Though for this person was a relatively short person, so for her, probably a little bit too large. But anyway, if we think of 10 to 12 centimeters normal, it's a normal size. And then the confusing part was those black areas or darker areas here that are not in the pylon area, so that's not hydronephrosis. You could think, well, these could be cysts, and often you can confuse them, but they're not completely anechoic, and they're very evenly distributed, so those are the pyramids. So the correct answer was normal kidney with no hydronephrosis and no cyst. All right, so well done. The next case. This is a 57-year-old man with a 5-day history of flank pain. It's the worst pain ever, and associated with nausea and vomiting. Blood pressure still normal, heart rate is up, he's a little febrile, he's in distress. We have no murmurs. He's tender on the right side. His creatinine is up, his GFR is maybe 17 or 18. Potassium is still normal on the UA, RBCs and white blood cells. So here's the question for you. What image modality would be most appropriate in this setting? Is it a CAT scan, CT angio with contrast? Is it a CT urogram with contrast, renal ultrasound and a KUB, ultrasound with Doppler and color, or a nuclear scan with furosemide? Now you can go. Thank you. To stop it at the end. Excellent. Let's see what we have. Fantastic. C, renal ultrasound and a KUB. Very, very good. I'll tell you it's right. Okay. So just to review the American College of Radiology appropriateness criteria for the case that we have, someone with flank pain, you could choose CAT scan with contrast and without contrast. We didn't get that option here. Ultrasound of the kidney, bladder, and retroperitoneum, we had that, and the KUB. And why is that? Obviously, we're looking for a stone, and we all know, or you all know, that probably the CAT scan or some sort of an radiographic imaging is better at detecting small calcified structures as compared to the ultrasound. But note here that actually in any kidney disease and hypertension, one of the methods of choice or more appropriate studies to do is ultrasound with Doppler if needed. And even when CAT scans are preferred, and we all know the limitations of our patients who have advanced kidney failure that we cannot use or do not want to use contrast, that ultrasound is always most likely always the diagnostic method of choice. All right, so here are the pictures of this patient who had kidney failure. We don't know if acute or chronic. He had flank pain, and this is the right and the left kidney. All right, and here are the questions. Do we have normal kidneys? Do we have kidney with we have a normal kidney on the right with a cyst on the left? Do we have a normal kidney on the left and hydronephrosis on the right? Do we have hydronephrosis on both sides? And do we have hydronephrosis on the right and a cyst on the left? One more time. All right, and then please choose. Oh, that was fast. Okay. All right, well, but I did confuse you a little bit, right? So, let me see. 55% are choosing E, which is the right-sided hydronephrosis and a cyst on the left. And the next answer was hydronephrosis, right and left. So let's look at how hydronephrosis looks like. So here we have a kidney with a pretty normal-looking parenchyma, the hyperechoic area of the pelvis and of the perisinusoidal fat, and then the pelvis all of a sudden is appearing here as like a triangular dark structure with little calyces going all the way towards the parenchyma. So this is mild hydronephrosis. There you go. And pictures like this, where the calyces are much more dilated and it's a little bit kind of like a balloon already, it's already called moderate hydronephrosis. And in very severe and advanced hydronephrosis, you get these bizarre structures of something fluid-filled that you cannot really identify if it's what it is. Most likely it is hydronephrosis, especially if you see parenchyma like this. Polycystic kidney disease look a little bit different. So this is just to remind you about the grading of hydronephrosis. Grade 1, it's only the pelvis is dilated. Grade 2, calyces start being dilated. Grade 3, they are very plump. And grade 4, where you don't see any clear structure of calyces. Now, it is important to always remember, and a constant debate between neurology and nephrology, I don't know how it is in your institution, but it's always in our institution, that we always debate, oh, who's taking care of this patient who's an AKI, his potassium is 6, and you have mild hydronephrosis. And everyone's like, well, it's only mild, and no, and this is not a urological problem. And we'll say, well, that's not true. We think this is a neurological problem, then because even if you have mild hydronephrosis and not an impressive picture, hydronephrosis can be obstructive. So bear in mind the difference of obstruction and hydronephrosis. And how do we figure that out? How do we figure that out? What test? Say it again. You want to see how fast the unit red went up. That could be one argument, but the urologists don't take that usually. Nuclear medicine scan with furosemide. It's the test that will prove obstruction versus no obstruction. So urodynamic obstruction. And these are the situations where you don't have to have a lot of hydronephrosis, where you have patients with retroperitoneal or fibrosis or tumors, early and sudden obstruction, prerenal state. On the other side, you have patients who have massive looking hydronephrosis, either in pregnancy or megacystic megaureter syndrome, and they have no dysfunction from this. So image of hydronephrosis and obstruction is not equal. Oops. The answer was diuretic renogram. All right, so let's look at structures again. If you have a kidney, this is a liver, with a big black round structure with the phenomenon I was telling you about, dorsal enhancement, then you can be pretty sure that this is a simple cyst. We have no septae or anything, but black with dorsal enhancement. That's how cysts look like. On the other side, if you have hyperechoic structures with shadows, acoustic shadowings, that is nephrolithiasis. As I mentioned earlier, a CAT scan is especially sensitive for smaller stones and stones that have migrated in the ureter. That's an area where ultrasound is not really perfect. So if the choice would have been CAT scan without contrast for our patient, probably would have gone for that, but the option was ultrasound plus KUB, and you have all chosen that, voted on that correctly. So the answer was renal ultrasound and KUB. So in summary, B mode, so the brightness mode ultrasound, is very valuable to look at the size of the kidneys, the aspect of the kidneys, to exclude hydronephrosis, to look for polycystic kidney disease, the bladder, perinephric collections. It is pretty good, but not perfect for stones. Masses identification for extension, you probably need another imaging modality with contrast. And it's great for biopsy, for kidney biopsies, if the body mass index of the patient is not too high. Overall, every single patient who has kidney disease or hypertension should have at least one kidney ultrasound among their studies. Do we do ultrasound in transplant patients? Of course, and should be done. Same questions that can be answered. Very good for biopsies. Everything is, you don't need CAT scans usually to do a transplant kidney biopsy. It is very important to perform serial exams, especially in the early phase after the kidney transplantation. All right. Last case, 77-year-old female, stage 3 CKD, hypertension, has had radiation, has had aortic surgery for aortic occlusive disease, had a spinal fusion, had a lot of antibiotics, and comes to your clinic complaining of edema. You have prior values of a creatinine of 1.1, then 1.3, 1.5, 1.9, 2 in August when she presents to you. Blood pressure, only one medication, controlled at home with 100 milligram metoprolol. She's a little bit more hypertensive when you see her in clinic. Her JVP is elevated, she has edema, and now creatinine is 2.1. Her GFR is down to 22. She's not really proteinuric, no hematuria, no casts. And you have kidney size 9.4 and 8. No post-void residual. What would be the next appropriate step in the diagnostic for worsening renal function that you would choose? And here are your choices. Nuclear scan to look at the differential renal function, Doppler ultrasound to look for renal artery stenosis, CAT scan for detection of nephrolithiasis and masses, MRI for nephrolithiasis and masses, or CAT scan to detect bilateral renal vein thrombosis. All right, you can choose now, pick now. All right. Wonderful. Of course. So we have heard earlier size difference of the kidneys, smaller kidney on one side. We should think of vascular disease. There's a few other red flags in here. Radiation or prior aortic surgery for atherosclerotic changes. So definitely something to think about. You may wonder, it's like, well, she's not really hypertensive at this point, but reality at home and then what you measure may be very different, and you can have renal vascular disease without severe or refractory hypertension, as in this patient, in any way. So yes, the answer is correct. So let's look at the pictures of the imaging that we do for the Doppler. And just to remind you of the anatomy, we have the aorta, the IVC, and the celiac trunk, AMS, and renal arteries come off right after the aorta comes through into the abdominal cavity through the diaphragm. So it's relatively high in the epigastrium. On a transverse cut on a CAT scan, this is how it looks like. This is the aorta, this is the IVC. The AMS comes off anteriorly, and then left renal artery about 4 p.m. if you look at it as a clock, and then at 9 a.m. is the right renal artery takeoff. So you kind of have to keep in mind anatomy. As I mentioned, the ultrasound is done relatively high in the epigastrium, which is actually good because there's the least chance of having air overlapping the area. And this is the picture that you obtain. And this is anterior, this is posterior, remember? The liver is the first object you will see. This is the spine with a shadow, so it's hyperechoic with shadow. Aorta is round, IVC is round, often bigger than the aorta. AMS, and the left kidney and the right kidney. Now to see the renal arteries, it's a little bit tricky. You have to really know what they are and what also helps, but here's in magnification. If you're lucky, you can actually see them on B mode, but they're about 4 to 5 millimeter big, so not easy to be seen. So what helps is to use color Doppler. And color Doppler, just to remind you, is not showing artery and vein, it will show direction of flow. So if you point towards the aorta a little bit inclined, looking towards the heart, the blood in the aorta will come towards the probe and will be red. And then the renal arteries are actually blue because they go away from the probe. Here's your probe, and the vessels go, and the blood flow goes that way. So that's why you see them here in blue, blue and blue. Now, how do we see stenosis? So looking at the principles of hemodynamics, you have flow volume into a big size diameter pipe, and then it all has to go through a smaller diameter pipe. So, and the Bernoulli formula says that the velocity in this area has to be equal to the velocity, the product of velocity and area have to be equal in those two parts. So the only way everything can flow through the smaller diameter pipe is to increase the flow velocity. And that's what happens. The velocity increases, and everything above 2 meters per second is indicative of a stenosis greater 60%. This is pretty much true in every vascular bed if you look at the carotid artery, the mesenteric artery, or the kidney arteries. This is 60% stenosis, so in terms of looking at studies and what should you dilate or not, I think you've heard talks on that, but 60% may not always be hemodynamically significant. In any way, so we're mapping the vessel, the right renal artery, measure velocities and serve several spots, 200 centimeters per second, maybe there's a 60% stenosis. On the left side, the flow velocity is 4.5 meters per second, that clearly indicates a high-grade stenosis. Now, you have the option to actually look also at the kidney level, into the intrarenal arteries, the segmental or interlobar arteries, and measure something called the resistance index. It is not so popular in the US as it is in European countries, but it actually adds a lot of value to the interpretation of the results. And if the spectrum in the kidney, in the segmental arteries, is taken, you will see that there's a continuous systolic flow and a continuous diastolic flow. That is typical for low vascular resistance beds. And the relationship of the systolic and diastolic flow velocities are plugged into this formula, which you won't remember, you don't have to remember, and you get usually numbers that are somewhere between 0.5 and 1. 0.6 to 0.7 being said to be normal, though I do have to point out that it varies actually depending on the age of the patient, the placement of the probe. So you need to understand a little bit more about resistance index to really kind of plug it into your overall interpretation of the picture. And high age, stiffness of the vessel, and nephrosclerosis will increase the resistance index behind a stenosis. Remember, the stenosis in the renal artery, and you're looking at what arrives in the kidney, you'll actually have a low resistance index. And just to show you what happens, and what you probably often or sometimes see, is this parvus and tardus description of the flow profile, which means that the amplitude is decreased and the acceleration time is increased. The wording you remember from aortic stenosis, so this is equivalent to there is a stenosis on the way to the kidney. So even if you can't see the renal arteries itself, if you have a very low resistance index and this parvus tardus phenomenon, that actually tells you that there is a high-grade stenosis. So the combination of the two will help you increase sensitivity and specificity. The alternatives in patients who have AKI are you can't give contrast. CAT scan MRIs are difficult, but I want to point out the option of non-contrast MRIs, which use either arterial spin labeling or different techniques to actually show you relatively well the renal arteries. So that's your option if you don't have Doppler or the patient is too heavy and you have AKI. The kidney transplant can be evaluated just the same. You look at the perfusion, you look at the renal artery, and remember there's a iliac artery on the way to the kidney, which is kind of the extension of the renal artery, which can as well be stenosed and cause dysfunction and hypertension. This is a spectrum that I'd like you to just take it in as a picture, because it's something that is rare, but it is important. If ever a kidney transplant has this systolic upstroke and a complete negative diastolic flow, that's a very bad prognosis for this kidney, and in 95% of cases this will be a complete renal vein thrombosis, which requires immediate intervention. So think of that, remember this when you see this pattern. Color and Doppler is very good for evaluation of renal artery stenosis, transplant perfusion, AV fistulas from after biopsies, which I haven't shown, and for transplant renal vein thrombosis. Evaluation of tumors, you can use color, but it's not perfect, and you need additional imaging. And renal vein thrombosis of the native kidney is another very difficult diagnosis with any kind of modality. So in summary, ultrasound is great, it is inexpensive, it is non-invasive, it is non-toxic, you can repeat it as much as you want, you get a lot of information. The only thing that we always hear is like, yeah, it's operator dependent, but everything is operator dependent. A CAT scan can be interpreted in different ways if you go and ask two different radiologists. So keep that in mind. So keep using it and believe in ultrasound. It is a very valuable tool. I'm just going to point out the value of it in the assessment of the volume. We can use very small probes, meanwhile, that are hooked up to your cell phone and look at the IVC diameter, effusion, ascites, and look for the A lines and B lines in the lung. It's a very helpful tool to evaluate intravascular and extravascular fluid. The IVC ultrasound looks for a very wide IVC that is non-collapsing, and these numbers correlate relatively well with increased right atrial pressures. A pleural effusion, just so you've heard it, you can see with, for example, this is normal, this is the diaphragm, this is the liver. Usually if there is no fluid, it looks gray like this, and it's actually a mirror image artifact of the liver. But if there is fluid, you see the spine continuing, and it's called the positive spine sign. So pleural effusion is present. Here is ascites is present as well. And A lines and B lines in ultrasound, those are artifacts, but if you have this picture, it means lung is aerated, versus this comet tail artifacts that look like little rays going through the pictures. Those are B lines. Those indicate you have interstitial edema. So coming to the end, I do think, and it's advised even by all societies, to actually obtain an ultrasound in every patient who has kidney disease or hypertension. It's a valuable tool for the volume exam. Always look at the pictures. Don't just take the report that is presented to you. If you can add this as to your toolkit, it is great. And of course, we have different imaging techniques that we need to use in conjunction with each other. There's not one good single tool. We just have to know what's right at the right time. And thank you very much.